I'm Dr. Prashant Srivastava. I'll be speaking about OOPS in glaucoma and overview of surgical complications and their management. So most of things are already discussed in the last presentation. So I'll briefly discuss the complications and their early management. So complication can be of two types: intraoperative and postoperative complications, in which early and late postoperative complications. So the first complication, which could be a conjunctival buttonhole, which is already discussed by ma'am, that we have to use a non-tooth forceps to prevent such buttonholing. And if a buttonhole is small, we can leave it. If it is larger, then we can close it by a tensor nylon or tensor bicycle suture. And generally, they do very well. So we can close it like this. Next is scleral flap damage. This can also happen. So now we have to see at what stage we have a scleral flap damage and what is the extent of the damage. If the damage is of small amount, then we can repair it on the table there only. And if it is larger and we have created a surgical, and also we have to see whether we have created a sclerostomy or not. If not, then we can move on to some other site and we can patch the area with scleral patch graft if the damage is more. So I'll share a video. I'll show a video which can explain the procedure. So vitreous loss can also can happen in ophthalmic eyes and eyes with aphakia and post trauma. In such cases, anterior vitrectomy may be required. Now bleeding, as Dr. Parul has already discussed the how to prevent bleeding in a case of while performing a trab. We have to stop anticoagulant 5 days before the surgery, and also we have to give the maximum control of IOP. Mannitol should be given in all cases. In such a way, bleeding can be avoided. So pre-operative, we have to identify the risk factor, discontinuation of anticoagulants. At intraoperative, we can use brimonidine or apraclonidine, and we have to minimize the handling of tissue. We have to be very gentle, and we have to maintain the intraocular pressure while doing the surgery. And once a suprachoroidal hemorrhage is suspected, we have to close all the wound immediately and try to form the AC. Flat chamber can happen in suprachoroidal hemorrhage, and in such case, management will be sealing all the wounds completely.
No, I told him that he's already.
Now this is a surgical video which explains how the scleral flap tear is managed. This was a small tear, so it's a combined phacotrabeculotomy in which crescent is used to to enhance the flap size. So now we can see the next step. There is a small tear. So this tear is formed in the sclera. So what is the next step? So we go deeper in the sclera. So next plane is selected. We go deeper, and sclerostomy is done anterior to that area which is affected, and the rest of steps are similar to that of the normal trabectomy. The defect is closed by tensor nylon suture, and this patient did very well. So it's a small tear which can be repaired very easily. So next complication which I would show is premature entry. So this is a case of childhood glaucoma in which these eyes are really bigger eye, so the sclera is very thin. So in ophthalmic eye, sclera is very thin. It's difficult to make us flap sometimes because of things. So this sclera is very thin here, and while making the flap, there premature entry happened. And then what is the next step? We form the anterior chamber, and then further and after placing the pre-placed suture, then the PI is done at different site, and then the wound is closed. So the conjunctiva is closed now. So this patient also did very well. Now next, coming to the post-operative complications. So in the view of time, I have only I'm seeing only two cases. So this is a 54-year-old female who had a primary open glaucoma and IOP on maximum AGM. So TRAB MC was tried on third post-op day. So the wound is leaking, and you can serial test was positive here, and wound is leaking. So it's a case of wound leak, which is very common complication of a limbal fornix-based trabectomy. So once you see there is a wound leak, the eye should be patched, and we can see the patient next day. So the patient was seen on the third day, and eye was patched and called fourth day. The leak was still present. Then a large side BCL, generally 14 to 16 millimeter. 16 millimeter is ideal, is applied, and then we can follow the patient. So the 60 millimeter BCL is very much helpful in closing such conjunctival wound leak. So generally management is conservative. We can patch the eye. If there is no response, then BCL and tissue adhesive can be tried. The second case is a case of overfiltering blebs. A 62-year male patient in which a phacotrabeculotomy is done. The first post-op day, the IOP was very good with a deep anterior chamber. Wherever the seventh post-op day, IOP was high with shallow bleb. So a releasable suture was removed. Bleb formed on the table, was looking very good. But when the patient returned on 10th post-op day, there was hypertony with shallow anterior chamber. We can see in the slit picture, the shallow anterior chamber with a big, large diffuse bleb. So this is a case of overfiltering bleb, where we have a shallow anterior chamber, low IOP, but there is no leak. There is no. It's not a bleb leak. It's a overfiltering bleb. So to deal with overfiltering bleb, uh, the loose scleral flap is the reason, and if you remove the releasable suture very early in post-op period, then you can have such scenario. The management is giving cycloplegia, pressure patching. In the cases which are not responding to this, we can try deepening the anterior chamber viscoelastic or non-expansive consideration of gas. Larger, if the hypertony persists for a longer time, then we can have suprachoroidal effusion. Then we have to sometimes drain, or may have to start steroid for 3 or 4 weeks. Now this is a late post-op complications. We have a cystic bleb. So such cystic bleb, if rupture, there is impending rupture, then we can do a conjunctival rotograft, and sometimes if the sclera is also very thin, they can put a patch graft. So I have shared only few complications in the interest of time. Thank you. Yeah, thank you. Yes.
Thank you very much for those beautiful presentations and the videos. Now, the last patient that had overfiltration, did you do anything to the steroids? You know, because initially you had good, the pressure was high. At the time that the eye started overfiltering, did you lower the steroid? Because sometimes if you reduce the steroid, you may have a bit of adhesion. You know, the inflammation then helps, and that can also reduce it. And then do you also consider transconjunctival suturing when you have overfiltration in such cases? I find that's a lot easier, even maybe better than injecting viscoelastics and all that, because once you do that, the pressure goes up and then you seal off the hypotony. Thank you.
Conjunctival suture sometimes can have a tendency to cheese wire over time. So you have to be careful. I mean, you'll end up using a nylon, and sometimes they can cheese wire, especially if the conjunctiva is very thin and you've applied mitomycin C. So then those become a challenge, and I've seen two such cases where you have this really sharp vertical cut through the bleb and they're leaking through it. You release it, but so you have to be careful. Only an invasive procedure if required. But the first technique is to try and manage it medically. Very often it does settle down.
So
and steroids,
do you think the steroids? Yes.
Yes, tapering the steroids help.
Yeah. Right. Thanks.
Yeah, I think more for wound leaks than for overfiltering blebs, because the pressure onto the bleb area with these bandage contact lenses is not good enough for the filtration to slow down. But for the leaks, it works fairly well. It works fairly well. I am not, I don't shy away from resuturing the conjunctiva if I can see a gape, because sometimes the longer you let the bleb leak be there, the future of that bleb is not so good. These blebs scar down much earlier. So really doing something very quickly to try and fix the leak is very helpful to maintain the longevity of your bleb.
I have a question. I used to do standalone trabs under an air bubble in the entry chamber. Now I've shifted to viscoelastic. What does the panel do?
What viscoelastic do you use?
Normal Viscomed.
So I use only sodium hyaluronate for the reason that I don't overfill the chamber or fill it completely, but a very little amount, so that you don't have the hypotony and very significant fluctuations. And it's very easy to press the scleral lip and it pops off because it's so cohesive and not dispersive. So I only use that. With methyl cellulose, the reaction in the eyes, the inflammation that it generates is so much that your blebs tend to behave differently with methyl cellulose. So I don't use that at all. I try and stick to fluid and air. Rarely, if I really need high risk patients and all, I use sodium hyaluronate, and I pretty much on the table make sure that it has come out while I'm checking for my filtration. That's my technique.
What I do is after the scleral suturing, I do an INA, complete INA, and then I suture the conjunctiva.
Yeah, because I think it's very important. will always induce some amount of inflammation.
So there's a lot of inflammation.
Any one of the others, it won't.
Right.
So
So it's better to use a sodium hyaluronate like now.
or even a
Methyl cellulose
I
especially.
prefer
Avoid,
if she's
yeah.
talking about a cohesive, I prefer a dispersive.
Okay.
And then I don't have to wash it off. It's more difficult to wash off, but it takes care of those micro leaks for a few days. It's a personal choice which you'll finally.
But you have to remember that the pressures in that case will be a little high initially and it'll automatically get better. I'm sure you see that because of that retained little bit, but they don't cause
Right.
inflammation.
And I think be careful if you're leaving an air bubble in a fake eye. Never. So that's
Yeah.
And even
So I think
I
I've shifted from
avoid
air
the-
bubbles
yeah.
now.
Yeah.
Even-
Washing away a visco is not easy, even with a bimanual.
and not good for a fakey eye. I mean, you don't want to. So we
Of
try
course.
and not even enter the anterior chamber much, except for using the fluid to just go into the chamber and
Right.
check for filtration. Nothing really enters into the pupillary area.
Yes, she has.
Sorry, so the panel, the cause of the problem in the last patient was because of the early removal of releasable. What time do you think is ideal to take it out? What has worked for you?
Yeah, so it depends on how many sutures do you have in place, what kind of mitomycin C have you used, and what pressures are you seeing in the post-operative period. Normally, releasables we don't touch in the first week, 10 days, but there are some situations where it's super tight and you on the table are also having problem with filtration and you've put 3 releasables and all. Sure, you can go ahead and release one.
Oh, wow.
If you're sitting in 35, 36, you can do that. But otherwise, after week 10 days, in the first few days, a little bit of massage and all you can give. That helps you deal over the pressure fluctuations.
Okay. And what about when you have a high pressure in assessing your patient? When do you think it's safe to do gonioscopy to see whether it's the ostium that is blocked? Do you think it's something you can try second day post-op?
Immediately, yes. So if you have high pressures post-op, you want to know the cause.
Yeah.
So you would, if it's in the
So the
second or
gentle
third
one.
post-op day that you're seeing, most probably because of your ostium getting blocked.
Yes.
So
Okay.
you need to do a gonioscopy to check.
Thank you.
See, I think it's a good idea to do some massage and see if the bleb is forming, the pressure is getting released. That means the ostium is working fine, and then you can plan for an early suture removal starting from 1 week post-operatively. Wait till that time. But if the pressures are still continuing to high despite massage, there's a blockage in the ostium and you have to tackle it.
And also, if you have an ASOCT available, you can always use that because that will be totally atraumatic.
That's a good suggestion. Yeah.
Thank you, sir. Thank you.